I am so pleased to introduce to everybody Tamara Melton, who will have a session for us today called How Diversity at All Levels Supports Regenerative Practice. If you are a registered dietitian or a registered nutrition or dietetics technician and are seeking continued professional education for Tamara Melton's presentation and panel discussion, please email us and include your name and your CDR registration number, and we will send the link to the evaluation and then your certificate of attendance, and we will put that information into the chat for you. And then I'm just very delighted to introduce Tamara Melton. She's the co-founder and executive director of Diversify Dietetics, a nonprofit seeking to increase the racial and ethnic diversity in the field of nutrition by empowering the nutrition leaders of tomorrow. She has worked in the food service industry as an advisor, admissions counselor, and nutrition faculty member at Georgia State University, and was the inaugural program director for Georgia State's Lewis College Health Informatics undergraduate and graduate programs. As the program director, she has implemented several unique strategies to attract and retain Black, Indigenous, people of color, and first-generation college students in the health informatics programs. For those of you in attendance, we will have a panel discussion where she will answer questions at 4 p.m. And also that panel discussion will be approved for 1 hour of continuing professional education. And there will be a Q&A following her presentation. So please do post your questions in the chat. Welcome, Ms. Melton.
Thank you so much. Can you guys hear me okay? Hopefully, yes, okay. So I don't know if you saw me just a second ago. As soon as I start a virtual presentation, my daughters always burst in. They are 7 and 9. So one came right in, I'm like, get out. So she bounced back out. So I just sent our tutor a message to ask her to keep them, but they may make an appearance. So thank you so much, Dawn, for that great introduction. I'm going to attempt to share my screen here. So give me one moment for that. And let me see, here we go, perfect. All right. So I'm going to tell you a little bit more about the work that we do at the nonprofit that I co-founded, Diversify Dietetics, a bit later on. But I'm really interested or really excited to speak on this topic about diversity at all different levels of practice and how it supports regenerative practice. And I do want to start off with this question, and you can drop it in the chat. I'd love to see what your thoughts are on this question here. When you think of certain foods as healthy, why do you think of those foods as healthy? So we just had a whole discussion about gardening, and we know that fruits and veggies are healthy. That's one of those things across the board. For me, as a dietitian, I know that people, they're always expecting me to be looking at their plate to make sure that they're eating foods or veggies that come from the food place, which dietitians are not. I always tell people we're the most fun people to eat with because we absolutely just love food in general. But outside of that, when you're thinking about actual eating patterns, why do you think of certain foods as healthy? And it's kind of a trick question because, and I love the chats that are coming in. Elisa says her mom serving what she got served, and you love the taste of them, vitamins and minerals. So anything healthy and spicy. So we all have foods that we grew up with eating, and that definitely influences what we decide to eat. Also, what we decide is important to us and why we choose our foods. And then also our culture could be important as well. In the United States, though, we have different organizations that oversee our food supply. So if you're getting food supply from general grocery stores, even to the level of, I'm going to click it here, your food labels that you're looking at, um, the USDA and the FDA, USDA especially, has a major influence on, for many people, what's considered healthy. Now, speaking to us in this room, we're a little bit different of a crowd, right? So it's different than asking, maybe if you're to go out into the public and ask them, why do you think something is healthy? But people will see different images and they'll get a lot of nutrition education. We have it for children in schools, preschoolers actually, in the school, and then all the way up through the college level. What you see on the fronts of your packaging, if something is considered low calorie or low in cholesterol or heart healthy, all these different terms are terms that are created from work that is done from folks who are at USDA and the FDA and the labeling. That's how all of that comes through. And then also thinking about programs like SNAP, which is overwhelmingly, because what we're going to be talking about is diversity, overwhelmingly helps, I shouldn't say overwhelmingly, but also serves a lot of people of color in the United States, as does the National School Lunch Program and the breakfast programs. In fact, SNAP, about 38 million people in the United States participated in SNAP or WIC, so that program in 2019. And the National School Lunch Program feeds about 30 million kids a day. So there's a lot of meals going out, and what's considered healthy is because of these guidelines that we have from these two organizations. So how are these standards actually set? Who decides what's considered healthy on the standard for the general public, what people are deciding? So there's this huge document that comes out every 5 years called the Dietary Guidelines for Americans. Came out very late last year just because of what was happening with COVID. And this is basically the document. If you want to spend some time and read an interesting doc, you can read through what these guidelines look like. And these guidelines in the United States go to create visually for us what's considered my plate. I want you to keep this image of this plate in your mind, and you might remember, depending on, I think all of us are of age in this room, to think about when we had the pyramid before the plate, which nobody ate off of a pyramid. So that was really confusing for people. And even before that, we had like a square graphic. I can't remember exactly what it was called, but we had a square graphic, but there's all these different graphic representations, which are trying to take what are in these standards, what are considered healthy, and put them into what we would kind of eat off of, an image that we would eat off of. So if there are all of these standards that are feeding millions of people, and feeding millions of people who sometimes this is their main way of eating. This is where they get most of their food from. If it's for children at lunch or breakfast at school, or if it's someone who's participating in a SNAP program, then this is where they're getting a lot of their foods from. So who's deciding what is considered healthy? Well, these are the folks who did for the last dietary guidelines. This is what they look like. And you probably will notice there's not a lot of diversity in this group. And that's the point that I'm getting to with this. So I don't envy the job of this committee by any means. The United States is not a homogenous group of people. We are one of those countries that has so many different people from so many different cultures. And you're trying to find, and of different income levels, backgrounds, values, beliefs, and you're trying to work together to create what is considered a healthy eating pattern for all these different people. So there's definitely information in the dietary guidelines that says that this has to be individualized for people. But as far as the cultural diversity, I don't know exactly where every single person is from, but if you're looking for people of color, which I often do as a person of color, which I think a lot of people do who are people of color, you just kind of look initially to see who was on here, you notice there's not as many as you have. And somebody just put in the chat something I'm going to get to in a second about how we have a plate graphic and people don't even necessarily eat off of a plate. But these are the folks who are making the decisions, and going forward, they are the ones who are considered experts. And also think about where they're getting these recommendations from. They're from researchers who are creating what's considered evidence-based practice. So there's evidence-based recommendations that have all these studies that are done, and they're going to be giving us large sets of data to let us know what could hopefully prevent disease and keep someone healthy. And I always ask people, well, who are the people who are conducting those studies? And who decides what foodways get to be studied and what's considered healthy? It doesn't take you very long to realize there's not a lot of diversity in the whole pathway going towards what we are told, as many Americans are told, is considered healthy. And this is, like I said, beyond what's considered our fruits and vegetables. So I'm a registered dietitian. I love our field of nutrition and dietetics. I think that we are really fortunate to be able to work with people from all different backgrounds. And in the dietary guidelines for Americans, they did put into cultural considerations as, or cultural traditions as something to consider. And they gave kind of a shout out to those of us who are nutrition professionals. And they said, rely on the expertise of professionals in nutrition and in specific cultural foodways can help people prepare foods healthfully while retaining their heritage. Just a little background of the type of education that we have. It was mentioned that I have been an educator for basically all my career. I started teaching at the college level at 23. Um, and there are a lot of courses that we take in sciences, biochem, things like that. We could probably, now while dietitians, most of us are not looking at what you're eating and judging your plate, we probably could look at what you're eating and break it down to the chemical structures. That's just something that we have. We can actually look and see what is something is made of. But if I'm not familiar with what you're used to eating from your culture, I may not be able to do that as well. I just may not know what that a cassava is similar to yuca, is similar to potatoes, is similar to rice, right? If I'm not familiar with those foods. And that just may be because of what I ate growing up and what was presented to me in the textbooks that I read. Now, remember, I was talking about who actually writes a lot of these things that are considered evidence-based, that all of these different healthcare providers are being trained by. And so, particularly in our profession of nutrition, this is what we look like. So, our profession is overwhelmingly white and female. It's overwhelmingly, we have about 95% of our practitioners are women. There's probably a lot of reasons for that, but there are quite a few women. But just in general, it's an overwhelmingly white profession. And this is the reason why, when I was an educator and one of very few people of color, not only in my class, not only in my university, any conferences that I went to, it was kind of like one of those situations. If I saw another person of color, we do like this slow run across the hallway to each other just to hug each other, because we never saw anyone who looked like us. And I had the opportunity, as was mentioned at the beginning, Don mentioned, I was able to start a health informatics program, so a health IT program. I was teaching at a university here in Atlanta where I live. Georgia State University, right in downtown Atlanta, graduates the most Black students in the country. So it's not an HBCU, but because there's so many students there, they graduate about 5,000 students a year, and the majority of them are Black students, but the students are from really all over the world. And so I was teaching these students first these intro to nutrition courses when I first started teaching. And then I started teaching more higher level nutrition courses. Those entry level courses were very diverse, looked very similar to the rest of the campus. But as we got more into my program, into our actual nutrition program, it looked like this. So you go out into this university, it's very diverse, but our programs, in fact, all of the programs in our health professions were mostly white, even though we're in this very diverse campus. So I had the opportunity to be promoted to start a health IT program. So I actually left my home discipline, went over to start a health IT program. And this issue of us not having a lot of diversity in our profession was really bothering me. So I asked my dean if I could accept any student that I wanted. And this is going to be important as we go further on in the conversation. And she said, as long as they're in the university and as long as you graduate them, you can take any student that you want. So without telling anyone, I went on a quest to try to recruit and retain and graduate as many students of color that I could. And so that's what I did. I intentionally hired faculty who'd help to support these students. We created a schedule that would support students. Many of them were first generation college students. Many students were refugees. Many of them, English was not their first language or even their second language. This might have been their third language. They were all brilliant. They were all really hardworking, but they needed to have a schedule that would support them in actually being able to go into their program. They needed to have folks who would allow them to be themselves in the classroom, to have their own personalities, to have this environment where they could really flourish and succeed. And they did. So I was about 4 years into actually having graduated with along with my faculty. We graduated several hundred students, and the majority of them are students of color. And health IT at the time, this was not about 2013. It wasn't an easy pathway to go into. A lot of them didn't have a healthcare background. And so they were trying to go into a really fast-paced changing field. If you're familiar with healthcare, around that time is when a lot of technology was coming into healthcare. And so they were coming into what was a challenging field. And to me, having gone through, I also went back to school at that time, graduate school again, to get a degree in health informatics. And it was about as hard as the courses I took in nutrition. So I'm looking back at my home discipline and saying, this doesn't make any sense. If we're able to recruit, retain students of color and get them through this health IT program, which is just as hard and just as challenging, in my opinion, as nutrition, then why don't we have it in nutrition? And so that was when the seed of the idea of eventually the nonprofit Diversified Dietetics in my head was planted. But looking back at this graphic, knowing even the Dietary Guidelines Committee considers nutrition professionals as experts who should be helping people to understand how they can use their own cultural foodways and eat them in the healthiest way, it doesn't look like we have a lot of representation in our field of nutrition and dietetics. And I'm not just saying dietitians are the only ones who can speak about nutrition. I'm not one of those RDs. Every single person eats, and a lot of people have a lot of knowledge about food, and it goes beyond the sciences. But specifically in our field, where we are a lot of times the ones who are called up to ask to work on a lot of these larger government level programs to create these different foodways and recommendations for foodways. So just a little chat about what it looks like when there is who decides what is actually considered healthy. And it's no secret, I think, anymore that in the United States, the dominant culture is European and of European descent. And just thinking about the dominant culture as one that's considered having greater access to resources and influence, they're also the ones who get to decide what the cultural norms are and decides the distribution of resources, and the environment is organized to meet the dominant culture's needs. Well, what does that look like in the grocery store? Well, if you think about the non-dominant culture is, these are folks who have historically had less access to resources and influence. They have to conform to rules and norms set by the dominant culture, and the members of this group, non-dominant culture, may have solidarity based on a shared struggle. So these dominant and non-dominant cultures can apply to anything. We're talking about food and to nutrition and what's considered healthy. But speaking about food and nutrition specifically, I like to ask people, when you go into the grocery store, where do you see like the cultural foods at? There's a lot of times there's this one or two aisles that you can go to, right? And the grocery store that I have that's across the street from my house, so it's pretty close. It has two aisles, and it's interesting how they break down. There's like Latin American foods, and then we have Asian foods. That's so bizarre to me that we have Asian foods, Asia being a huge continent with many people on it. And then there's like these different categories, and the rest of the grocery store is the dominant cultures, right? It's what is considered to be the dominant culture's way of eating and food ways. Where this came into an issue I saw when I was a student with my classmates was that people were not familiar with other food ways. They were not familiar with other cultures' food ways. And because there were not as many classmates who they could even look to who were from other cultures, because we were all, it was so much lack of diversity there, they couldn't even ask their classmates about it. What does that mean for creating standards of what's considered healthy, or somebody deciding to research a certain culture's spices that they may eat, their food ways that they may have? We just had a discussion about gardening and how that's so important for Black Americans and what that looks like. I cannot tell you the discussions we've had over the years about soul food. I'm going to do that in air quotes, and how that's not considered healthy. and how I've had discussions with colleagues so they would even understand, remember, these are food nutrition experts, why Black people eat some of the foods that they eat and how the access to the foods that they could get during slavery, during Jim Crow, even now, we've talked about food apartheid, food deserts, and why that affects people's access to foods. And so this lack of diversity within our profession, which then trickles down into all the communities that we work with, definitely has had an effect that we have seen. Oops, trying to move forward. So I want to speak specifically about the healthcare system, and not all dietitians work in healthcare. Like I said, we work in many different areas, and but we do work with people who, in the clinical setting, or even like an outpatient setting, but more in a clinical environment, where they may have a medical condition that we're helping to support: diabetes, heart disease, hypertension, all those sorts of things. And I've had sometimes discussions with my colleagues, my white colleagues, who will say, well, I don't understand why a patient wouldn't be comfortable sitting with me and talking to me about something. In fact, some people have said to me they think it's reverse racism, which I've kind of had to explain to them doesn't exist. But they'll say to me, like, I don't understand why people aren't comfortable. And I showed this image of these gentlemen here at a conference in Arkansas. It was in 2018 to a room of 150 dietitians. I was doing a keynote talk there. And if you know who these gentlemen are, you can definitely drop it in the chat. But I asked all of my colleagues there who have all taken a health ethics course if they knew who the gentlemen were. I didn't expect them to know them from the image, but I did ask them. Remember, I'm in Arkansas in the South. Did ask them if they knew about Tuskegee. And there were some people who were like, oh, yes, the airmen, that's a great story. It's so wonderful. It was so inspiring. And I truly sat there and said, not the airmen was a great story and it was inspiring, but not the Tuskegee Airmen. Do you know about the Tuskegee experiment? And there were 3 people in a room of about 150 people who raised their hand and said that they knew about that story. So in case you don't know about it, I do want to spend a little bit of time telling you about the Tuskegee experiment and how this affects how some people feel about healthcare providers in the United States. So the Tuskegee experiment was an experiment that happened to a group of men where there was an agency that was testing treatment for syphilis. At the time, there was no known treatment for syphilis. So there were about 600 Black men in Tuskegee, which is a town in Alabama, that were enrolled in the project. And the participants were primarily sharecroppers, very poor then, and many had never visited a doctor before. And the doctors were from the US Public Health Service. And if you know anything about the US Public Health Service, you know that they are the precursor to what is now known as the CDC, the Centers for Disease Control. So it was the CDC. They were running the study, and they informed the participant 399 of the men had latent syphilis, and there was a control group of 201 others who were free of the disease. They told them that they were being treated for something called bad blood. And that's a term that's commonly used in the area that would refer to various ailments. So these men thought that they were getting this treatment. So remember, some of them have latent syphilis, and there's a control group that doesn't. So the men were monitored by health workers, but they were only given placebos, such as aspirin and mineral supplements, all of the men who had syphilis, the men who didn't. Despite the fact that penicillin became the recommended treatment for syphilis in 1947. So by that time, this study had been going on for about 20 years. The researchers convinced a local physicians in Macon County, which is where this was occurring, where this study was occurring, that they shouldn't interrupt the study. They wanted to keep it going because they wanted to see how the disease would play out. So they convinced the local physicians not to treat the participants, and the research was done at a university, at Tuskegee Institute, which is now Tuskegee University. And in order to track the disease full progression, the researchers provided no effective care, and the men proceeded to die, or they went blind, or they went insane, or they experienced other severe health problems due to their untreated syphilis. By the mid 1960s, so now we're about 20 years later, 20 years later, a US Public Health Service venereal disease investigator in San Francisco named Peter Buxton, he found out about the study. He wasn't a part about it, but he found out about it this time. And he expressed his concerns to his superiors that this was unethical. In response to this, the officials formed a committee to review the study, but they ultimately decided to continue the study with the goal of tracking the participants until they had all died, the autopsies had been performed, and the project data could be analyzed. So Mr. Buxton actually leaked the story to a reporter friend at the Associated Press. And Jean Heller is the name of that reporter. And Heller eventually broke the story in July of 1972. So we're now a good 40 years later. And of course, at that time, there was a public outcry and the study was shut down. By that time, 28 participants had died of syphilis, 100 more had passed away from complications. And this is the part that really gets me. At this time, 40 spouses had been diagnosed with the disease, and 19 children had contracted syphilis during this time. So I say this story and tell it at length a lot of times to students who are in the healthcare professions, to let them know, and then ask them to look around at what happened in the last about 15 months with COVID, and ask themselves, why do some people, when they ask, have prefer to work with practitioners who look like themselves? And I'll remind them of this here. So that is an issue that we have when we don't have more practitioners, more diversity in our practitioners of who we're working with, not just in nutrition, but just in healthcare as a whole. Another thing that's come up pretty recently, this was in about a year ago, this came out, that this study hit the news, that Black newborns are 3 times more likely to die when looked after white doctors. And so this is just another example of how there is a real, true understanding of why there's a distrust of providers in the healthcare system overall. And our profession is not the only one that could stand to use a lot more diversity. You see, and these are the faculty who are considered racial or ethnic minorities. In medical school, it's 4%, physician's assistants, 7.6%. We see a bit more in public health. And we've seen that this is really important because diversity in faculty helps to attract students. It helps to, we know that students, if you've ever worked with them, they can all be very different in the way that they learn and the way that they like to interact with their peers, that they like to interact with the faculty members that they work with, their advisors. And it's really important that the faculty themselves have diversity within themselves to be able to take care of all the needs of all the students that they work with. And across the board, when you look at programs that are teaching and training students, we see that there's definitely a need for more diversity there. It's not just in the nutrition profession, as we can see, it's in other professions as well. And providers of color, the research has shown that providers of color are more likely to practice in underserved areas with larger racial and ethnic populations. And they're also more likely to serve patients of color who are uninsured or underinsured. And they bring to their colleagues, like I was mentioning to you, for the nutrition profession, they bring to their colleagues the knowledge that they may have from their backgrounds, from what they might know, from the patients or clients that they may work with. You can go and ask a colleague who might have more familiarity, or there might be someone that a patient might prefer to work with. Because that person is someone they can relate to, or that they might have an increased sense of trust with that person. So when we don't have more providers of care or from different backgrounds, then we just don't have more of these folks to be able to rely on when we are providing this care to the communities that we work with. And we've talked a bit today about, and I know we'll talk later on as well with the next speaker, as to looking at what are all the reasons why someone may, whatever their health standards might be. And we're looking at things like their education level, their access to healthcare, the neighborhood that they live in, their communities that they have. And these social determinants of health, as they're called, are sometimes not included when there's conversations about people's access to food, what they consider eating, why they consider eating the things that they do, what they're familiar with, and all these sorts of things. I love that we're having the conversation about gardens and showing people what, especially children, what food looks like when it's growing, but adults too, because it allows them to have something that's missing that might be determining their health, because there's so many more reasons why someone is maybe healthy or not healthy based on where their environment is at. And the social determinants of health, I'll tell you, is something that in the studies that or in the training that we have as nutrition professionals, and then therefore trickling down into the groups that we work with, has just really started ramping up. And there are definitely some programs that do a better job than others at explaining this information to their students. I'm going to stop sharing just for a moment, just because my slides are not working. Give me 1 second, sorry. Continue on. Great. I'm so sorry. I'm going to do this. Okay. And then we'll jump back into it. Technology is getting me today. One moment. Here we go. Okay. Perfect. Hopefully you can see my screen again. So how to increase diversity in any workforce? I put this in here because I think that there's a lot of different areas where we need to see more diversity in the workforce. I talked about 2 different areas of us and under our profession of nutrition, both in practice and in the training of future professionals. Pipeline programs are so important. At our nonprofit, the nonprofit that I co-founded with Deanna Bellany Lewis, who's my co-founder, I wanted to take what I had tried in that health informatics program and create an organization where we could apply this to students all across the country. So I wanted to go beyond just our program there at Georgia State University, but go across the country. And so we do have pipeline program, which I'll tell you a bit more about in a moment, but pipeline programs can be in any area, any place where there needs to be more diversity. If people look around and they see that everyone looks like them. I've had this conversation with colleagues who will say, oh, we need more dietitians of color. And I'll tell them, we can't just waltz into this field and decide to become dietitians. And there are many fields, even if there's not a credentialing like we have as nutrition professionals, where people just can't waltz in. Why? They may not have the access to it. They may not have the resources to be able to start a program. They may not have the understanding of being able to access an educational pathway or a career pathway. So pipeline programs are extremely important, but well-made pipeline programs that really elevate the ones who are leaders, who are from diverse backgrounds, whatever that might be, to help to design the programs are really important. And then these programs need to be flexible in the way that they're assessing what's considered success with students, with the if it's professionals that you're working with, anything like that, because without these sorts of programs that can really help to level people up, to give them resources that they may not have access to otherwise through no doing of their own, then we're not going to be able, excuse me, to be able to make a lot of changes in these workforces that need more diversity. Even now that I'm an executive director of a nonprofit, it's really interesting that so many nonprofits are targeted towards assisting people of color, but very, very few leadership are people of color. Very, very few, which is really interesting to see. In the educational space, and I have a lot of these conversations with colleagues, looking at admissions practices. I just gave a talk to a group of nutrition educators, so they're all faculty members of dietetics programs, and I told them, there's no accrediting agency that says you have to have a 4.0 class. There is no accrediting agency. There's no accrediting agency that says you have to have a 3.5 class. And the reason why that's important, if you have students who are working Sometimes they may not be a straight A student because they're doing the best that they can when they're going through their program. Or if English is not their first language, they may not have the most pristinely written essay. And if anybody is trying to write something in a language that's not your native language, I guarantee you, if you ask me to write something in any other language than English, because that's the language I know the best, I'm not going to write it that well. And there are these bottlenecks that are being created that do not necessarily translate into someone's ability to be a good whatever it is that they're trying to become because of the way that they're being assessed. Remember, by the dominant culture's perspective of what someone should be like when they're going forward, and to be able to access a profession or a field. And then recruitment, retention, promotion strategies. This can be in university level. It could also be at the level of any organization that we're looking at. And I want to bring these two up here because I think that sometimes there's a thought, especially lately, with everything that happened in 2020, where people think, you know what, you're right, we're not diverse. So we're going to grab the person, and we know them as a token, who is the closest to what we could think can be a leader. And we put this person into this position, but there's not really any sort of resources provided to this person to make them feel included, to make them feel protected, to make them feel that they're actually valued. And then even in some areas, there's a situation where a colleague goes from what's called a pet to threat phenomenon. So they come in and everybody loves them. You're so great. We're so happy to have you here, et cetera, et cetera, et cetera, and those sorts of things. And then it transitions into, we don't do things that way. That's not the way that things are done around here. Why are you doing that? And then in many cases, and you can Google this, there was an article, and I can't remember the organization. I'm going to try to look for it while we're in between before the panel that talks exactly about this, but it talks about how people of color are brought into organizations. They are given just enough resources, but not really enough to be successful and not really enough support to really be successful. And they eventually go to becoming a threat, and things start to look like, and it starts to feel like to them, and rightfully so, this is not made up, it's actually in their head, it's actually happening, that now many of the things that they were praised for when they first came in are now considered a threat, and many people leave. Thank you so much. You found it, Lisa. Thank you. That was exactly what I was thinking about. Was that. So in the chat, you can check out that article. And I talked to a lot of colleagues and asked them about this. And where this is an issue, we've seen in our nonprofit where we finally get a student of color, who comes through, becomes a dietitian, and then they have such a bad experience with their colleagues that they decide to leave the profession. We have quite a few like that. So they're brilliant. They often go off to become doctors, nurse practitioners, which is great. So they have this nutrition background and they are in this care setting, but we actually lose them in the field. It's as if we're trying to fill a bucket up with a hole in it. Sometimes we're trying to keep people in the profession. So just to tell you a little bit about something, let's end on a happy note. When we started Diversified Dietetics, I remember when I was sitting in class with a medical nutrition therapy class that we take as students. So this was me young, traditional college student. And I remember reading a line that said that Asians and African Americans are more likely to have lactose intolerance, period. That I remember looking like, are we going to talk about more? Like why this is happening? Like, is there any reason why? Nothing in the textbook went any further than that. And you've probably heard a lot of discussions lately now where we talked about the social determinants of health, where we found that many people who have what are considered chronic diseases are higher risk for diabetes, higher risk for hypertension, higher risk for heart disease, actually has a lot to do with the environment that people are living in through no choice of their own, the trauma that they've experienced, their access to care, and many other factors that have to be, that can be tied to structural racism. And not a lot of that is taught in programs. I'm saying this as someone who is an educator, who's had a lot of conversations with colleagues, because when you have folks who have not come from that background, they have not been exposed to people from diverse backgrounds, they're also thinking, oh, this must be true. This must be what's going on. And this must be that people are not eating as well as they should. They just don't want to eat the vegetables or fruit, or they don't want to go out and walk, not thinking about, do they have a safe place to do it? Or things like that, or even the Black community for Black women considering their hair. I mean, things like that have to come up. And at that time is when I thought, and as I progressed to becoming a faculty member, we just need more people of color in this profession. There's hands down no other way that we're going to be able to change things and be able to support all the communities that we serve if we continue the status quo that we've had going on since forever, for the 100 years that dietitians have technically been a profession. And that's why, for me, the idea of the nonprofit came up of creating a space. So what we've done is create different programming that helps to recruit, attract, and retain students of color and then professionals of color in our profession. And we have trainings for all professionals, so everyone who's in the profession, to help them to support their to support anybody that they work with. So no matter what the background is of the client that they work with or patient, they can support them. And so this is a group of young, I say young people, some of them might be a little older, but we had meetups before COVID. We would just arrange meetups around the country, and we've had a couple of them out of the country, where we just wanted to create a space where people could come and meet each other who are in this profession and not be the only one in the room. So this is a meetup that we had in Harlem. So that's one of the programs that we have to provide for our members of our community. And we also have other programs, like this was a meetup we had in Atlanta before COVID. We also have programs like educational programs, really hands-on. We try to have one-to-one care for the students, helping them to understand the educational pathway. We don't have a very simple educational pathway in dietetics, which often causes a lot of obstacles for students to get into. It's expensive. So we've now recently been able to offer scholarships to students, helping them to get through programs and their courses. Some students may have to retake a course, something like I said, we're a really science heavy program, as we should be, but students have the ability to get through if they have the right support. Sometimes some students, just depending on their background, might struggle with being the only person in a classroom. That's something that mentally they are just not quite able to bear. And so just having the support of knowing that someone else may not be in their exact program, but someone else is there for them is helpful. I mentioned our professionally focused programming that we have, and we also have programming specifically for educators. Educators, I like to remind my educator colleagues, are the ones who get to decide what this profession looks like. And in a lot of different professions, if there's a credentialing exam or there's a standard that we have that someone has to go through some sort of an educational pathway, those faculty members, so if you remember that data on diversity of faculty, those faculty members are the ones who decide what whole professions look like, because they're the ones who get to decide who comes through the pathway. So we have programming that's specifically for educators, really giving them resources that they can have to help to support their students, diverse students, recruit them, take care of them in their programs, really help to nurture them to get them through the whole educational pathway. And then we learned recently that we received word that we are able to start our own graduate level program through Diversified Dietetics to be able to train students. So we'll be starting that in 2022. And we're hoping with that program to be able to grab more data and provide more information for our colleagues who are looking to bring in more diverse folks in the program. And so just getting back to why diversity is so good. When you have diversity in a classroom, and you can apply this also to any space that you work in. Previous speakers talked about, I love that, how people were coming together to buy leeks and okra, and just because people got in the same space, they learned from each other. This happens in the classroom too. It helps to improve teaching and learning, to break down stereotypes. It helps to enhance civic values and promote democracy. And I mentioned about students of color and their loneliness and isolation. If we have more diversity in the classroom and really in any space, that helps to really just bring out much better quality of care for everyone, even in that space, and then the communities that we work with beyond that. And so we can never forget that food is culture. It absolutely is. That's why very specifically in our profession of nutrition, but I think anything that has to do with food, anything that has to do with food and touches that really needs to take into consideration that it is so closely tied to someone's culture. Someone mentioned in the chat, even with the My Plate. So think about that. I've had a lot of people say, where I'm from, we don't even eat on a plate. Everything's in a bowl. right? So even that representation of what's considered healthy eating, even the dish that it's in might need to be a little bit different. All right, thank you. I think I stopped a little bit early. Yes, left a couple minutes. I will stop sharing.
Ah, that is so wonderful. I thank you so much for bringing in all of these elements together to put it into context for us, how we are bringing in diversity, inclusion, making it about equity, making it about change, broadening our lenses to what's out there in nutrition. It's so important for our communities to understand this and be in dialogue together. And with that, I think we might have a question or two. Um, that somebody said they just marked themselves with an A. Do different diverse groups, are there, meaning Black, Asian, South Americans, um, I think that this question is referring to representation within the nutrition and dietetics fields. Are you seeing that there is need for diversity in those areas too?
Yeah, so the numbers are encouraging for well, for most groups of color. So I talked about gender, so we definitely need to work on that. Well, I think we need to have a lot more gender in diversity in our profession. So that's one thing. But as far as our groups, we have seen the numbers increase, and we are to representation for and I hate to lump a group and say Asian people, but if you take people who identify as Asian, we are representative in our profession. That's come over time, but if you go to the subgroups, I bet we're not. So once you go into the subgroups, we're there. We have seen year over year for students who are Hispanic, Latino, so Latinx communities, we've seen over 100% increase in students who are going into the field of nutrition. So we're seeing some really good numbers there. So that's exciting to see. We are seeing kind of a flat line of students who are indigenous, and that's because of the way the data is collected. It's a little bit hard to track them. We have two main agencies in our field of nutrition, and one is the one that credentials us as dietitians. The other one is that trains us in the education, and they don't they're working on making this actually align, but they don't track those groups the same, unfortunately. But we are seeing some flat line there, which is better than where it was dropping off. Unfortunately, Black students has been falling, so we're about 20% down over the last 20 years, and we expect with COVID we will see that continue to drop. So as far as we definitely need more representation in the Latinx community to reach the level of representation for the United States. We absolutely know that we need to in the Black community, because only 3% of dietitians are Black. That's about 2,000 people. When you really think of it, it's 2,000, about 100,000 dietitians in the country. So there are some groups that could use some work, but we are seeing some progress with other groups. And our nonprofit works with students who are of color from any background. So we work with all of them.